Hi, I'm Daniel Butler. I'm a board certified dermatologist. I work at the University of Arizona, where I am the vice chair of education, and I lead a research program called the Inflammatory and Aging Skin Research Program. And we look at how aging is a risk factor for many of our inflammatory skin diseases. And we try to unpack all the levels of that. Yeah, that's an easy answer. So I have always felt very comfortable with older adults, and I have the four greatest grandparents of all time who made me really appreciate aging and understand that yes, there are things that we don't like about the visual signs of aging, but there are things about aging that are inevitable and wonderful, like experience and relationships. And so I really wanted to dive into this funny place that dermatologists live, which is that we do a lot that's anti-aging focused, but we also see a lot of older adult patients who are part of this inevitable aging process. And so I thought it'd be a fun juxtaposition to be part of both sides and do research that is looking at the healthy aging side. One piece of advice always turns into four, so I'll give you sort of my tagline pitch and my what I always like to say to early careers or people who don't necessarily identify as seeing older adults, but they're starting to is while age is just a number, the moniker of getting older affects everything. It affects our basic science, our pathophysiology. It presents how diseases present, and perhaps most importantly, it changes how we interface with our medical system. And so I think any APP, any physician who is working with patients should know that every level of practice is affected by getting older. And sometimes it's as small as a disease looking a little bit different. Sometimes it's a lack of understanding of what a specialty pharmacy is and that a prescription is not going to go directly to the local pharmacy and having to spend a little bit more time to counsel somebody through things can be a part of that. So anyway, know that it affects all levels of practice. It can be very small, if not nothing different than a younger patient, but it can also be large and change the entire way that you approach a patient's visit for something that you diagnostically know exactly what's going on. Yeah, I think the misconception is sort of hiding in plain sight, and that's that older adults and younger adults are the exact same. And a lot of the times when we talk about geriatric dermatology, people will say, oh, that's not a thing, it's just general dermatology. And while I agree with that statement, I think it's part of our skills as general dermatologists are to make sure that we are meeting the needs of unique populations. And so when it comes to something like psoriasis, where it's very important to highlight that there is a second peak of psoriasis that happens a little bit later in life, 60s, 70s, even 80s, where someone can present for the first time. It's important that you're understanding their disease, not just from a visual standpoint, but really getting to understand what's bothering them. Is it the joint pain? Is it the visual? Is it a mix of the two? Sometimes, does it even bother them? And all of those elements should play a role in how we decide to treat that patient. But then on top of that, there's other details like what will their insurance pay for and what do their costs look like? So let me tell you a very common example here, particularly when it comes to psoriasis and some of these advanced therapies, is that 5 years ago, before we had the Inflation Reduction Act, many of these patients would get from Medicare an agreement or a coverage agreement that says, okay, we agree that this medication is approved, but the patient would then get a thirty to $60,000 bill. I even had one patient get $100,000 bill because Medicare says we approve it, but you have to pay for it out of pocket. Now, the Inflation Reduction Act has reduced out-of-pocket maximums to somewhere between $2,000 to $3,000, but it's still really important that we as clinicians know that for someone on a fixed income, for $2,000, that may be too much if their first bill comes in January and they have to pay $2,000. So we've started to see advocacy across those lines from industry, from the insurers, from the payers, and from the dermatology community to figure out ways to navigate this. And so the reason why I'm putting this all out there is because it's really important that a physician or an APP knows that nuance of prescribing in this specific population and is able to counsel somebody on it, help guide them through it, and then make sure that their expectations are met when you see them on that visit. Because it's not as easy as I see the disease, here's the medication. It's much more nuanced than that in this population.